So we left in the previous video from the poliomyelitis. It is the destruction of anterior horn by poliovirus, fecal oral transmission, and replication in lymphoid tissue of oropharynx and small intestine. This is the underlying behind mechanism, that it is the replication in the when there is fecal oral transmission and we get bacteria, this virus in our GIT tract. There is replication in the lymphoid tissue of the oropharynx and small intestine, and then from here it is spread to the CNS via the bloodstream. Acute lower motor neuron signs. So this showing asymmetric weakness and symptoms of viral meningitis. What are the symptoms of viral meningitis? It is fever, headache, and neck stiffness. Respiratory muscle involvement lead to respiratory failure, and CSF shows increased WBCs, lymphocytic pleocytosis, and slight increase of protein with no change in CSF glucose. Poliovirus can be isolated from stool or throat secretion. So the diagnostic test is CSF examination, and in this we will have increased WBCs, lymphocytic pleocytosis, which means we will see more lymphocytes, and slight increase of protein with no change in CSF glucose, as this is a virus and doesn't need any glucose for energy. So glucose will have no change in the CSF examination. Poliovirus can be isolated from the stool or throat secretion. So as this is a fecal oral and the virus gets in the GIT tract, so there is a remnant of the virus in the stool and throat secretion, as we know that replication occurs in the oropharynx and small intestine. So the next in spinal muscular atrophy. It is the congenital degeneration of anterior horn. As there is no anterior horn, there would be no supply to any muscle, and due to lack of supply, there would be no function in the muscle, and the muscle will get atrophied. So this is spinal muscular atrophy due to congenital degeneration of anterior horns. It is autosomal recessive SMN1 mutation encodes survival motor neuron protein, defective SNRNP assembly, lower motor neuron apoptosis, spinal muscular atrophy type 1 most common. It is most common. Spinal muscular atrophy type 1, and it is also called Wernig-Hoffmann disease. Lower motor neuron signs only. It is symmetric weakness, floppy baby with marked hypotonia. It's flaccid paralysis with tongue fasciculation. So it is as it is from the birth, so it would result in floppy baby with marked hypotonia. There would be hypotonia and flaccid paralysis, and tongue fasciculation can also be seen. So this is the location where the defect occurs. The next one is amyotropic lateral sclerosis. These are the combined upper motor neuron and lower motor neuron degeneration, and there is lesion at the corticospinal or corticobulbar and brainstem and spinal cord lesion. It is usually idiopathic. Familial form less common. So this is combined upper motor and lower motor neuron lesion, and the lesion is at the corticospinal, corticobulbar, and brainstem or spinal cord level. It is usually idiopathic, familial form, less common, may be linked to SODI1 mutation. It is SMN1 mutation. It is SODI1 mutation. It encodes superoxide dismutase. Amyotrophic lateral sclerosis is also called Lou Gehrig disease. It is also called Lou Gehrig disease. It is also called Lou Gehrig disease. So, it is a lower motor neuron sign. Flaccid limb weakness. It is a flaccid limb weakness. Fasciculation, atrophy, and bulbar palsy. Dysarthria, dysphagia. Lower motor signs. As lower motor sign, we have discussed it previously. It has some kind of uh, low mean less features, so less intensity in features. So it is flaccid limb weakness, fasciculation, atrophy, bulbar palsy, in which we can see dysarthria, dysphagia, tongue atrophy. And the upper motor neuron signs are spastic limb weakness, hyperreflexia, clonus, mean rigidity, and pseudobulbar palsy. In this, we have dysarthria, dysphagia, and emotional lability. No sensory or bowel deficit. Fatal, most often from respiratory failure. Treatment riluzole. Treatment is riluzole. Tabes dorsalis. It is degeneration, demyelination of dorsal column and roots by Treponema pallidum. Tertiary syphilis. It is a feature of tertiary syphilis in which there is degeneration, demyelination of dorsal column and roots by Treponema pallidum. It causes progressive sensory ataxia, impaired proprioception, poor coordination. There is positive Romberg sign and absent DTR associated with shooting pain, Argyll-Robertson pupil Charcot joints. It is associated with shooting pain, Argyll-Robertson pupil. Argyll-Robertson pupil is a very common feature of Argyll-Robertson pupil, which you can remember from P, R, and A, which means that pupillary reflex absent, pupillary reflex absent, and Charcot joint disease. So the next one is subacute combined degeneration. It is demyelination of spinocerebellar tract, lateral corticospinal tract, and dorsal column. SCD due to vitamin B12 deficiency. There is ataxic gait, paresthesia, impaired position, vibration sense, plus Romberg sign. Subacute combined degeneration. If we split the name, there is degeneration or demyelination. So it is the demyelination of spinocerebellar tracts, lateral corticospinal tracts, and dorsal column, which means there are a lot of tracts in this disease. So it is combined. Subacute, which means it is from for a short period, not for a long period. So it is due to vitamin B12 deficiency. There is a ataxic gait, paresthesia, impaired position and vibration sense, positive Romberg sign, and upper motor neuron sign. So anterior spinal artery occlusion, as the name indicates, spinal artery which supplies to the anterior portion of spinal cord. So there would be lesion at the anterior side of the spinal cord. Spinal cord infarction sparing dorsal column, as the dorsal column has another supply. And Lissor tract, dorsal column and Lissor tract. Watershed area is mid-thoracic anterior spinal artery territory, as the artery of Adam Kiewig's supply. So ASA below T8, anterior spinal artery below thoracic artery 8 is involved in this. Watershed area is mid thoracic anterior spinal artery territory, as the artery of Adam Quick supplies anterior spinal artery below T8. It can be caused by aortic aneurysm repair. So it presents with upper motor neuron signs below the lesion, corticospinal tract, and lower motor neuron signs at the level of lesion's anterior horn, where there is a defect in the anterior horn, and loss of pain and temperature sensation below the lesion, spinothalamic tract. Let us again we see it presents with upper motor neuron signs below the lesion at corticospinal tract level, and lower motor neuron signs at the level of lesion, and loss of pain and temperature below the lesion, spinothalamic tract. So if spinothalamic tract are involved, then there would be loss of temperature and pain sensation below the level of lesion. If there is loss of corticospinal tract, then there would be upper motor neuron lesions, and lower motor neuron lesion would occur at the level of lesion if there is involvement of anterior horn. So watershed area is mid thoracic anterior spinal artery territory, as the artery middle gate supplies anterior spinal artery below T8. So this is very important disease which is Brown Squat syndrome. It is hemisection of spinal cord. If there is hemisection of spinal cord, what symptoms would we have? Number one, ipsilateral loss of all sensation at the level of lesion. So where this is the level of lesion and loss of all sensation, and ipsilateral lower motor neuron lesion, flaccid paralysis at the level of lesion. These are the two lesions which would these are the two signs findings which would have at the level of lesion. There is ipsilateral upper motor neuron signs below the level of lesion due to the corticospinal tract damage. Yes, as there would be damage of corticospinal tract, so we would have upper motor neuron lesions, as we have discussed it previously as in the previous slide 2. There is ipsilateral loss of proprioception, vibration, and fine 2-point discrimination touch below the level of lesion due to dorsal column damage. There would also be dorsal column damage, and as you can see, this half of the spinal cord shows all the tracts we discussed, like corticospinal tracts and dorsal column, and you can see spinothalamic tract damage. So if there is damage of corticospinal tract, we would have upper motor neuron signs. If there is damage of dorsal column, we would have loss of proprioception, vibration, and fine touch. And If there is damage of spinothalamic tract, then we would have contralateral loss of pain, temperature, and crude, non-discriminative touch below the level of lesion. If lesion occur above T1, patient may present with ipsilateral Horner syndrome as there is sympathetic ganglion at the above of T1. So due to this damage, there would be damage of the oculosympathetic pathways. So these are some signs. Let us see here again one by one here. At the level of lesion, there would be loss of all sensation and lower motor neuron signs. And below ipsilateral and below the lesion, there would be upper motor neuron sign and impaired proprioception, vibration, and fine touch. And contralaterally, we would lose sensation of pain, temperature, and crude touch. If there is hemisection of the spinal cord at the level of T1, we would have in addition the Horner syndrome. The next one is Frederick ataxia, very important disease. It is autosomal recessive trinucleotide repeat disorder on chromosome 9 in gene that encode fractalkine iron binding protein. Iron binding protein. It leads to impairment in the mitochondrial functioning. So in simple, there is this is autosomal recessive trinucleotide repeat GAA on chromosome 9 gene that encodes fractalkine iron binding protein. So there is mutation in the iron binding protein. It leads to impairment in the mitochondrial functioning, degeneration of lateral corticospinal tract, spastic paralysis, spinocerebellar tract ataxia, and dorsal column decrease vibratory sense and proprioception, and dorsal root ganglion loss of TDR. There would be other symptoms like staggering gait, frequent falling, as it is also a feature of ataxia, nystagmus due to spinocerebellar lesions, dysarthria, pes cavus, hammer toe, diabetes mellitus due to pancreas involvement, hypertrophic cardiomyopathy, which is the main cause of death.